Introduce our next speaker, Dr. Alexandra Thomas, who is here with me in person today. Dr. Thomas is the Williams Professor of Breast Oncology at Atrium Health Wake Forest Baptist Medical Center, and the title of her talk today is Management of Special Subtypes of Triple-Negative Breast Cancer.
Good afternoon. Thank you, Rita. I'd like to thank the organizers for the opportunity to speak on this important topic. Oops, how do we advance? How do I advance my slides? Okay, the roller. These are my disclosures. I've added to our title today, The Path Ahead, as we have relatively limited disease-specific information on treatment for now, but hopefully this is something we can collectively impact. I've outlined our discussion to include an overview of less common subtypes of triple-negative breast cancer. How do we identify these tumors? What is their prevalence? Hopefully I can convince you that we do see these tumors with some frequency. Next, we'll look at molecular and clinical features of these tumors, as well as treatment of individual special subtypes. Then we'll look at newer tools for risk stratification and therapeutic decision-making, and how these might be applied to special subtypes. Finally, we'll conclude by looking at how we might harness contemporary research tools to further disease-specific understanding. I think you'll see some recurrent themes with the talks we've just heard. To provide a framework for where we're headed, let's talk first about the take-home messages for this afternoon. First, given the lower prevalence, we have some, albeit limited, disease-specific information on how to treat special subtypes. As biologic principles applied to breast cancer, no special type, extend to less common subtypes, we can improve our understanding of this group of breast tumors. And we may need to think beyond the randomized trial to improve our knowledge in this space. While this afternoon's discussion focuses on triple-negative breast cancer, the points here could be applied broadly to rare tumors across the spectrum of breast cancer. I'm going to talk, too, about heterogeneity, which both of the other speakers have touched upon. When we talk about triple-negative breast cancer, again, this is a highly heterogeneous group of tumors, illustrated here on the left. Triple-negative breast cancers are really only unified by their shared lack of receptor expression. This heterogeneity becomes even more pronounced when we think about special subtypes of triple-negative breast cancer. To select the special subtypes to focus on, let's turn first to the World Health Organization classification of tumors. That's the little blue book shown here in the top right corner. While often used by pathologists, this book offers excellent reading for all clinicians involved in the care of patients with breast cancer. Listed here are the invasive breast cancers classified as epithelial tumors of the breast. We've classically defined special subtypes by histology, though increasingly, as we've heard this afternoon, molecular signatures are critical to our understanding of these tumors and will likely become central to their classification. Many of these subtypes are characterized by hormone receptor positivity and not the subject of today's discussion on triple-negative breast cancer. Several of these tumors are ultra-rare and will also not be our focus this afternoon, leaving us with this group of tumors. The first type, invasive breast cancer, no special type, medullary pattern, is no longer a special subtype at all. As with the most recent edition of the World Health Classification, it's no longer an independent subtype. Though as it was one until most recently, I'll discuss the reasons for this change and touch upon some of the literature in this area. Oops. This is a synopsis of the subtypes we'll talk about. Frequency is that for all breast cancers, and common receptor expression profiles are shown, though there are, of course, exceptions. In this highly heterogeneous group of tumors, there are a range of prognoses from excellent to quite poor. So how rare are special subtypes of triple-negative breast cancer? Let's think about this for a moment. One way to do this is in the context of other less common solid tumors. Shown here are esophageal and anal cancer. To start with, we have an apples-to-apples comparison of incidence per 100,000 persons in the United States, with rare breast tumors shown in the solid pink. Though for breast tumors, this is a large underestimation likely, as these tumors are more difficult to diagnose and have a variety of categories into which they can be registered. For example, for the classic metaplastic breast cancer shown there, subtypes which would not have been included in that count include squamous cell carcinoma, spindle cell carcinoma, carcinosarcoma, pleomorphic carcinoma, and others. Other series estimate that metaplastic breast cancer accounts for up to 2% of all breast cancers, depending upon the definition used. The continued use of overlapping or potentially related diagnoses is a confounding factor in our attempts to study rare breast tumors. Shown in the light pink to light blue bar on top of classic metaplastic breast cancer is the possible extent of this disease. Estimates for triple-negative invasive lobular carcinoma, which we'll discuss in just a moment, are based on a different series. Collectively, these tumors approach the prevalence of other, less common, but well-studied solid tumors. When one considers adding special subtypes that are hormone receptor positive, it becomes clear that patients with these tumors represent a sizable portion of our practices. Let's look at this another way. What portion of triple-negative breast cancers are special subtypes? Again, our information is limited by inherent issues with large databases. With the most prominent subtypes included here, special subtypes accounted for 7% of triple-negative breast cancers. So with this sense of the scope of the problem, let's review individual special subtypes and look at their molecular and clinical features, as well as what we know about treatment. Our first subtype, as I mentioned earlier, is no longer a special subtype at all, but now a pattern with an invasive ductal carcinoma, no special type. Relatively low reproducibility, or alternatively stated, high inter-observer variability, led to the reassignment of this group of tumors to invasive ductal carcinoma with the most recent World Health Organization classification. So while we may see this in even recent series, we should be unlikely to see this diagnosed prospectively. Many will now report this as triple-negative breast cancer with a dense lymphocytic infiltrate, as shown in the image here. These tumors are poorly differentiated and well circumscribed. The tumor pattern is also characterized by CK5-6 positivity, high TP53 mutations, and is overrepresented in the immune modulatory subtype of triple-negative breast cancer. This tumor classification has a body of literature which found, based on its prior classification, that despite aggressive appearing histology, these tumors tend to be associated with a good prognosis. They are overrepresented in patients with germline BRCA1 mutations, and several studies have found a benefit to chemotherapy, albeit a more limited one than that which we typically associate with triple-negative breast cancer. Are these the patients with triple-negative breast cancer among whom we may consider de-escalation studies, as Dr. Mittendorf just discussed, given their good prognosis and lymphocyte-rich tumors? I'm going to discuss next triple-negative invasive lobular carcinoma. You heard correctly, and your pathologist, your friendly pathologist, did not make an error. This increasing recognition of this less common manifestation of E-cadherin negative tumors. Histologically, they have apricot morphology, eosinophilic cytoplasm, and prominent nucleoli. The picture insert here is that of the ER testing of this tumor, which tested negative. A recent European series was able to provide detailed molecular characterization of dozens of these tumors. 74% expressed the androgen receptor, and 20% exhibited HER2 mutations. These tumors are also characteristically CK5-6 negative. Triple-negative invasive lobular carcinoma has represented 1 to 2.5% of cases in recent series on invasive lobular carcinoma. Reports on triple-negative invasive lobular carcinoma, while still small, with numbers ranging in the dozens, though it appears that these patients have a superior prognosis, and this is shown here in the figure on the right, with triple-negative IDC shown in green and hormone receptor positive invasive lobular carcinoma in red, and then hormone receptor negative invasive lobular carcinoma shown in blue. Patients with triple-negative invasive lobular carcinoma also tend to be older in age. Others have found that while the Ki-67 in invasive lobular carcinoma tends to be lower than that in invasive ductal carcinoma, all triple-negative, that those patients with invasive lobular carcinoma still have inferior outcomes. Comparing disease molecular subtyping between triple-negative breast cancer not otherwise specified and triple-negative invasive lobular breast cancer reveals some intriguing differences. Shown here is just such a comparison. Shown in blue is triple-negative breast cancer not otherwise specified, and orange, triple-negative invasive lobular carcinoma. Triple-negative invasive lobular carcinoma has an overrepresentation of luminal A and HER2-enriched disease and is less likely to be basal-like. Oops. The recent series from Europe found that with triple-negative invasive lobular carcinoma, prognosis is superior for those with luminal-type disease relative to those with non-luminal type disease. While androgen receptor was expressed in most tumors, it was more likely to be expressed in luminal type, and HER2 mutations, as one might expect, were in the HER2-enriched type. Other potentially targetable features which were overrepresented in triple-negative invasive lobular carcinoma were PIK3CA and DNA repair pathway derangements, as well as high tumor mutational burden. Our next tumor subtype is carcinoma with apocrine differentiation. This subtype is characterized by large cells, abundant eosinophilic granular cytoplasm, and enlarged nuclei with prominent nucleoli resembling apocrine sweat glands. These tumors also are frequently androgen receptor positive, as seen in the photo insert at the top right. They have features in common with apocrine metaplasia, and in 30 to 60% of cases can be HER2 positive. They tend to fall into the luminal androgen receptor and immune modulatory subtypes. Most are sporadic, but it's important to note these tumors can be seen in patients with germline PTEN mutations. With apocrine carcinoma, again, incidence varies among reports due to variability in making the diagnosis, as well as categorization into overlapping and related diagnoses. Relative to non-apocrine triple-negative breast cancer, patients with apocrine triple-negative breast cancer tend to be older and are more often white. These tumors also tend to be smaller and lower in grade. Data on prognosis have been mixed, but several studies comparing triple-negative subtypes support a more favorable outcome for patients with apocrine triple-negative carcinoma, and that's shown here in the series on the right. With triple-negative apocrine carcinoma shown in red, they tracked with apocrine non-triple-negative disease shown in blue, and not with non-apocrine triple-negative breast cancer shown in orange. Retrospective series support a benefit to chemotherapy in this population, and responses, as we heard earlier from Dr. Zhao, to anti-androgen therapy in triple-negative androgen receptor positive breast cancer have been reported. I'm going to get this right. Let's turn now to metaplastic carcinoma. Metaplastic breast cancer also describes a highly heterogeneous group of invasive breast cancers, which share the ability to differentiate towards squamous or mesenchymal elements. The metaplastic breast cancer, which I've shown here, features a spindle cell component shown on the left side of the first slide, with squamous features on the right portion of the same slide on the left. These features are enlarged in the figure on the right. Metaplastic breast cancer represents, again, 0.2 to 2% of breast cancers, depending upon the definition applied. Where do metaplastic breast cancers fall with regard to intrinsic subtype, as well as triple-negative breast cancer subtypes? Shown here is work from George Rees-Vielho's group. Most metaplastic breast cancers fall into the Claudin-low or basal-like intrinsic subtypes. In this work, tumors with a predominant spindle cell component were uniformly Claudin-low. The triple-negative breast cancer subtypes most commonly identified in metaplastic carcinoma were mesenchymal and basal-like. Tumors with a predominant chondroid component were uniformly mesenchymal. Luminal androgen receptor and immune modulatory subtypes were not identified in this analysis of 28 tumors. Metaplastic breast cancers have a range of potential targets, including DNA repair, PIK, MEK, and Wnt pathways. These possible targets vary by histologic component, as shown here. As we'll discuss further in a moment, immune therapy is also promising for this group of tumors, which have high PD-L1 expression and whose stem-like features may enable immune evasion and suggest vulnerability to immune therapy. Multiple studies have demonstrated inferior outcomes for patients with metaplastic breast cancer relative to triple-negative breast cancer broadly. This study compared outcomes by receptor-based subtype. Outcomes for triple-negative metaplastic breast cancer, by far the most common manifestation of this subtype, were inferior relative to triple-negative invasive ductal carcinoma, with the differences becoming more pronounced with disease stage. As many of us know, metaplastic breast cancer, as we know from the clinic, demonstrates response rates to chemotherapy which are lower than that which we typically associate with triple-negative breast cancer. Shown here on the left are pathologic complete response rates from single institutional series for patients who receive neoadjuvant therapy. On the right are response rates by agent in the early and late line settings. Again, we see that these are lower than what we're used to with triple-negative breast cancer. Still, multiple large registry series support a benefit to chemotherapy over no chemotherapy and a benefit to radiation over no radiation in metaplastic breast cancer. Reports of exceptional responses to novel therapies are increasingly observed. As we just heard, Jennifer Litton has reported on a rate of a PCR in a patient with a deleterious BRCA mutation who received PARP inhibition. Next is a patient we recently treated in North Carolina. She had returned home from Zambia, having undergone primary resection of a 10-centimeter metaplastic tumor in Lukasa. Shown here is her initial MRI in North Carolina. She had residual disease in the left breast, as well as in both the contralateral and ipsilateral axillary lymph nodes. She was treated as per Keynote 522. She had no evidence of distant disease, and at the time of surgery was found to have a PCR. In the late-line setting, we're hearing increasing reports of responses to immune therapy, as well as to novel agents such as busparlib, dabrafenib with trametinib, and apatinib. So how might we target these diverse disease vulnerabilities to improve our outcomes for our patients with metaplastic breast cancer? When considering disease space, intervention, trial design, and importantly, feasibility, this is an outline of a trial design favored at a recent retreat. This proposal would have patients with metaplastic breast cancer receive upfront chemotherapy with checkpoint blockade, followed by response assessment, with responders continuing on with standard of care and non-responders receiving treatment based on an on-study biopsy. This design has features of the Artemis trial as well as of the I-SPY trial, both of which we'll discuss in just a moment. Clinical trials which obtains disease-specific information in the rare disease space have been challenging to conduct. The cohort 36 of the DART trial, led by Sylvia Adams, is one recent example of success. The DART trial offered combination nivolumab and ipilimumab to patients across a large range of baskets. Cohort 36 studied metaplastic breast cancer and quickly completed accrual. Shown here is the swimmer's plot of responses. 3 responses remain ongoing, and all 3 responders have developed adrenal insufficiency. Importantly, responses were observed in patients without the traditional biomarkers for response to immune therapy, in patients with low tumor mutational burden, low PD-L1, and absent TEALs. Let's look now at 2 uncommon and intriguing salivary gland-type tumors of the breast, which have features quite different from what we're used to seeing with triple-negative breast cancer. Adenoid cystic carcinoma is composed both of myoepithelial and epithelial components. Classic adenoid cystic carcinoma has a cribriforming pattern and a basophilic matrix. These tumors commonly have a MIB and FIB fusion, and characteristically can also have MIB rearrangements or MIB amplification. 3 subtypes have been described: classic adenoid cystic, again by far the most commonly diagnosed subtype, and the less common, more aggressive, solid basaloid, and high-grade transformational subtypes. These tumors commonly present as a palpable mass in an older patient. Though triple negative, their prognosis is excellent and surgery is generally curative. Multiple retrospective series report no to limited benefit from chemotherapy. The two less common subtypes, solid basaloid and high-grade transformational, appear to have a more aggressive clinical course, and while numbers are small, a benefit to chemotherapy cannot be excluded. Let's talk now about secretory carcinoma, which has some features that we don't talk about often in breast cancer. Secretory carcinoma is characterized by the presence of large amounts of secretions, both intracellularly and extracellularly, and can look like thyroid follicles. Importantly, they exhibit a pathognomonic ETV6 NTRK fusion gene. This gene encodes for a tyrosine kinase that activates the RAS, MAP, and PIK3 pathways to drive oncologic processes. NTRK inhibitors, larotrectinib and entrectinib, which we don't use often in breast oncology, are available. And as highly active therapy exists for advanced forms of these cancers, it's critical that we identify them correctly. These tumors present as a slow-growing, often painless mass that can be associated with nipple discharge. Mean age varies by series, though it's generally 30 to 50 years of age, and it can occur in children. Prognosis, again, is excellent, and this disease is generally managed with local therapy. While rare, metastases can occur, and there is at least one report of an NTRK inhibitor being used to bring about a dramatic response in pediatric secretory carcinoma. Our last triple-negative special subtype is neuroendocrine carcinoma. When this tumor originates in the breast, the most common manifestation is that of small cell carcinoma of the breast, though large cell neuroendocrine carcinomas can occur. These tumors are characterized by high-grade neuroendocrine morphology, supported by the presence of neuroendocrine granules. Neuroendocrine carcinomas, in contrast to neuroendocrine tumors, are hormone receptor negative and may develop in a different pathway, as has been seen with pancreatic neuroendocrine neoplasia. PIK3CA mutations have been reported. The clinical implications of this are less certain. Small cell neuroendocrine carcinomas of the breast account for 3 to 10% of extrapulmonary small cell. The presence of DCIS or other mammary carcinoma supports a breast origin. And these tumors, it is critical to confirm that the breast lesion is not a metastasis from another primary site. Extrapulmonary small cell of the breast is more likely to present with limited disease, and survival with local and regional disease is superior to that of stage-matched small cell carcinoma of the lung. It's important to remember that these patients may be eligible for trials of small cell carcinoma of the lung, usually early phase trials. With this background, how might we navigate the path ahead to harness newer tools for the management of special subtypes of triple-negative breast cancer? Across the spectrum of breast oncology, we're working to develop tools which allow us to deliver precision therapy to individual patients, with the goal of giving each patient precisely the therapy they need and no more. In some cases, this is therapy de-escalation. In some cases, escalation will be required. In special subtypes of triple-negative breast cancer, there is limited information that is disease-specific, making the path less clear. How might new tools help us clarify this path? Shown here by disease subtype are molecular approaches which we've discussed. Do these have value in special subtypes? Probably yes, but we only know to a varying degree. Broadly speaking, the higher-risk tumors are candidates for therapy escalation and the low-risk tumors for therapy de-escalation, though of course exceptions exist in either direction. And it's important to remember that for individual patients, they may have disease which allows for treatment with subtype agnostic therapies, such as PD-L1 blockade in patients with high tumor mutational burden, or PARP inhibition in patients with germline BRCA mutations. A recent trial has provided us some evidence on tools which we can use to guide therapy in special subtypes of triple-negative breast cancer. Artemis, an MD Anderson trial, looks at triple-negative patients in the neoadjuvant space and has prospectively identified a group of patients with metaplastic breast cancer. Patients receive neoadjuvant adriamycin and Cytoxan with on-treatment response assessed after 2 cycles by ultrasound. Following neoadjuvant AC, responders continue on to receive standard of care, while non-responders receive therapy based on an on-study biopsy. Patients with metaplastic breast cancer are more likely to have higher rates of disease following AC. This trial has several important findings for us. First, patients with metaplastic breast cancer had an improved overall PCR rate. Artemis reported a pathologic complete response rate in metaplastic breast cancer of 19% in 37 patients. Shown here in the top left figure, as a reminder, are the PCR rates seen in the single institution series. Second, this report also found that, as with triple-negative breast cancer broadly, PCR correlated with improved survival. Finally, the demonstration that in metaplastic breast cancer, an intermediate ultrasound can be a good surrogate for outcome could allow us to limit exposure to inactive therapy. These findings make intuitive sense, but confirmation that these tools work in special subtypes is an important part of our path forward. Circulating biomarkers are emerging rapidly as tools for response assessment, which we're learning here at this meeting. Liquid biopsy may allow for real-time, non-invasive monitoring of disease response. This should also apply to rare tumors, and case reports suggest this is the case. In the case on the left, a woman with small cell carcinoma of the cervix had ctDNA levels track with initial response and disease recurrence. These findings also tracked with her imaging findings. In metaplastic spindle cell carcinoma, a patient with disease refractory to chemotherapy and bevacizumab had a marked response to ipatinib, and her tumor mutational profile tracked with these changes. We intuitively expected that these biomarkers could provide a roadmap to guide risk stratification and disease management. As we move forward, how might we make the roadmap even more clear as we think about how to treat these tumors? How can we get disease-specific information for our patients? So where is our information on special subtypes currently coming from? The information presented here today is largely from retrospective series of large databases, a small case series, and I've even shown you individual case reports. And while helpful, these sources all have real limitations. Yet currently, this is the best information we have. And I'm presenting it here at the San Antonio Breast Cancer Symposium, in the same rooms where so many trials have changed our practice. It feels like a stark contrast. So how might we get more information for our patients with special subtypes of triple-negative breast cancer? Can we conduct disease-specific trials? These trials, by definition, would have a smaller size. They're unlikely to be sponsored by industry. We really want to do a randomized trial to get a scientifically valid answer, but that may be impractical. Will we accept the statistical issues associated with this? Will centers open it? It's hard to open and operate trials which accrue only occasional patients, as all of us know. NRG or GOG Legacy has had success in this space, conducting multiple trials in rare tumors, but they've generally been single-arm and have required international collaboration. Will sustained international efforts allow for the conduct of trials in rare breast tumors? How else might we get disease-specific answers? Where have we been, or where could we be successful, especially as we move into 2022? The DART trial successfully embedded an uncommon breast cancer subtype in a larger basket trial of rare tumors. We could also seek to conduct retrospective reviews of recent trials to look for signal of efficacies and to gain more information. While retrospective, this could offer randomized results. We're currently working to do just such a review with I-SPY, where we have looked at a subset of the over 1,800 patients who have completed surgery. An initial analysis found that 5% of these patients had metaplastic breast cancer, with 9% having tumors of special subtypes. This makes intuitive sense when we realize that I-SPY has enriched for high-risk tumors. Perhaps we could place emphasis on identifying patients with special subtypes as they enter our trials. This is something Artemis included and something we're hoping to build into I-SPY 2.2. We may now, more than ever, be able to do this by harnessing tools such as virtual pathology. Finally, might big data, another novel technological tool, provide more disease-specific information for us, particularly on the most rare of breast tumors? Let's look at how this might work in I-SPY 2.2 a little bit more closely. Shown here is a general schema for I-SPY 2.2, which will activate shortly. For this iteration of the trial, our plan is to have pathology specimens for special subtypes flagged and then undergo central review for confirmation. We expect that this will involve 5 to 10% of patient samples. The patient pathway will be determined by response predictive subtype. However, we'll be able to track into which groups these patients with special subtypes fall and how they respond to different treatment arms. Finally, how might big data help? Real-world data can have applications in rare diseases when clinical trials are impractical. The FDA called this out in their guidance on how to use real-world data. Examples of how such data might be used to understand questions in less common breast cancer populations include a post-authorization safety study of trastuzumab and emtansine in low ejection fraction patients, or efforts to use real-world data to provide evidence to support a label expansion to include palbociclib in men. Thank you for taking this journey with me. To review, the key take-home messages are, we have some, albeit limited, information that's disease-specific and how to treat our patients with special subtypes of triple-negative breast cancer. As biologic principles applied to breast cancer, no special type, extend to less common subtypes, we can improve our understanding of these tumors. We may need to think beyond the randomized trial to improve our knowledge in this space. Shown here is the path in England near the hospital where the BRCA genes were first described. The 10,257 colorful stripes represent the 4 nucleotides of the BRCA gene. It's been 3 decades since the BRCA gene was first described. We've come a long way in those years to solving the puzzle of how to manage breast cancers driven by BRCA. Hopefully, as we move ahead in the coming years, we can collectively work together to solve the puzzles of special subtypes of triple-negative breast cancer. I want to thank my colleagues who helped me prepare this talk and those who have guided me along the way. I'd like to thank you all for your attention. Shown here is a photograph of Western North Carolina, where I'm from. I do hope you can all visit in person soon.
I think we can take some questions from the room if people would like to ask questions. And can we please get our virtual speakers up?